Hello, welcome everybody. Thank you for joining us for the American Music Therapy Association Grand Rounds Music Therapy Practice in a COVID-19 World. My name is David Knott, and I'm currently serving as a member of the AMTA COVID-19 Task Force, the sponsor of this Grand Round series. We hope you enjoy hearing some of the submissions to the AMTA COVID-19 songwriting contest as we just gathered. There's still time to submit your original song by October 15th. Please visit musictherapy.org under latest news for information on how to do that. We also encourage you to view the many resources on AMTA's COVID-19 webpage and reach out to us with questions and suggestions. Before I introduce our presenter for this session, I ask that you please keep yourself muted to minimize distraction for our presenter and other viewers. Also, attendees can use the chat to ask questions of the presenters. We'll have a 10-minute question and answer period toward the end of the session, and we'll have our presenters answering your questions then. Today's session is Telehealth During COVID-19, Experiences of a Clinician, Students, and Service Users, presented by Todd Schwartzberg, Masters of Education, MTBC, and 3 of his senior undergraduate music therapy students, Emily Yager, Elsie Korioth, and Emily Adamson. Todd Schwartzberg is both a professor and music therapy clinical coordinator at the University of Minnesota. Todd teaches classes, conducts research, and provides music therapy sessions for individuals with autism spectrum disorder and other developmental disorders. All telehealth sessions took place via the University of Minnesota on-campus music therapy clinic, but were delivered from each of their homes. So with that, I will hand it over to Professor Schwartzberg.
Thank you very much for that extremely kind introduction. And Andrea and David and the entire COVID-19 task force at AMTA, I just want to publicly say thank you so very much for the tireless work, number of hours, professionalism, resources, everything that y'all have been giving us, and I have no doubt will continue to give to us. So we all appreciate you very much. It's an honor and absolute privilege to get to speak to you all today. It's actually really exciting and humbling to get to see a lot of familiar faces, although I can't see all of your faces. I wish I could. I see a lot of familiar names. So yeah, hi Barb, thanks for waving. And Eugenia, I see you too. So anyway, I am excited to get to introduce our 3 students, and then I'll share my screen and we'll get going with the slides. So just a little bit about our amazing students that are here with us today. Emily Yager is beginning her final year in the music therapy undergraduate program at the University of Minnesota, and she hopes to work in pediatrics and/or in early intervention. Emily Adamson is beginning her senior year of the music therapy program at the University of Minnesota. In the future, she hopes to work in pediatrics and conduct research with family-based practices in music therapy, and she is also completing a certificate in American Sign Language. And Elsie Korioth is also a senior music therapy undergraduate student, and she hopes to one day get to work with children and adolescents. So it has been an absolute privilege to get to work alongside these amazing students for a few years. We are sorry to have to see them go in a couple of months, but we all know that internship always gets to happen at some point. So I'm excited for y'all to get to hear from the students and their experiences and also the service users' voices too. All right, so I'm going to share my screen. Hopefully I get this right. I'll bring up our presentation. Okay. So everybody should be able to see that. So as COVID began to impact everyone's lives, but specifically our lives at the University of Minnesota, not only in our teaching as well as in our ability to provide the best quality clinical services to our service users, we obviously were just like everyone else. We were like, what do we do? How do we continue this? How do we continue to provide the very best that we can for our students and our service users? And so we began to, or I began to, in this case, learn a lot of new words and terminology. And so I thought we would start out by just kind of putting everybody on the same page with this. So synchronous versus asynchronous, the way that we use those words is basically to differentiate between I am speaking to you live, not in person, and then asynchronous, I am not speaking to you live and I'm not speaking to you in person. So every one of our clinic sessions, in particular the sessions and the service users you're going to hear about this afternoon, they were all delivered in a synchronous format. We all gathered in our own homes using our own Wi-Fi, which was good or bad, and you'll hear more about that from the students in a little bit. But we chose that in order to maintain the relationship, the rapport, the working alliance, in order to maintain the ability to make progress towards the identified goals, that the synchronous route was going to be the best route for our current service users. We do recognize that there's pros and cons with that, and we're going to unpack some of that this afternoon. And we also recognize that there are some pros and cons that we will not be able to unpack this afternoon regarding asynchronous work. Many of our colleagues and some of y'all might know of the work that, for instance, Minneapolis Public School did back in the spring. I believe AMTA amazingly highlighted some of that work. A lot of their stuff switched over to asynchronous, and they created videos of music therapists doing some teaching opportunities, and then their students in the public schools then would watch those at their leisure. Okay. We also wanted to make sure that we continued to adhere to our data-based model. We did not go back and redo an assessment with each of our service users when we began the synchronous telehealth clinic services. We just continued the ongoing assessments that any of us would do in making sure that the clients were still able to receive the services that we were trying to deliver through the computer. But we continued to adhere to the database model as best as we could, guided by our initial assessment, and continued on through the treatment planning, the lesson plan writing, the goals and objectives writing, the data taking, implementation, and eventual discharge in May. As for me, and as for the stone that I was cut from, and many of y'all know me, I tend to be more cognitive behavioral in my approaches. So much of the work that our students do with these particular clients, and the work that I also did with these particular clients, more sat in the cognitive behavioral domain. And that just seems to work best for these particular clients and the goals and the skills that we are currently working on. And again, you'll hear more about some of those goals and interventions in a little bit. We then started to try to figure out what platform are we going to use? And I know that many music therapists around the nation were having these conversations. I was a part of some of those and watching a lot and listening a lot in Music Therapy United and Music Therapy faculty Facebook pages and in other conversations. And so I kind of did a pros and cons of Google Meet, Zoom, and Doxy. We elected at that time to go with Doxy. The reason we went with Doxy is because Doxy could assure at that time the highest level of protection of personal health information for the service users that we were going to be contracting with. Doxy was able to send me a contract that guaranteed that these are the protections that they will offer. And so I felt most comfortable with Doxy. At that time, Zoom did not have the encrypted password, ever-changing login, whatever they got now, they didn't have it back in the spring. I will tell you that now, and we started telehealth back 2 weeks ago, last week. Now that we've started back with telehealth with our clients, we have gone to Zoom because every single Zoom telehealth session is encrypted. It is a different password for each service user, each day, each time. And it seems to be a more stable platform. Doxy gave us, and you'll hear from the students in a little bit, Doxy gave us a lot of instability. And I don't know if it was because they were now being bombarded by who knows how many people trying to use Doxy. Most of our telehealth services are in the afternoon, and it seemed to be that Wi-Fi may have been a little bit more unsteady as the day went on. But regardless, we chose to go with Doxy, and you'll hear a couple of other pros and cons of Doxy from the students and see on their slides. Another theoretical orientation that I was very excited to get to basically roll out during this period of time is one that I have been noodling on for quite some time during the in-person sessions. And that is this idea of coaching. And those of us that have done research into or are engaging in or have engaged in any sort of family-centered practice are probably familiar with the term coaching as it relates to work from the early childhood area. And that's exactly what I'm talking about here. And so the students and I spoke about how in our telehealth sessions, we would incorporate 5 components of coaching. And those 5 components are joint planning, where in which at the beginning of the session, we as the service providers would do a very quick check-in with the caregivers as well as the service users to make sure that they were still in agreement with the plan for the day. It gave us a chance to also check in with them and just see how they were doing, and do we need to make any alterations or adaptations, modifications, et cetera, with our plan for that session. Then we would do actually a lot of observing. What we found out as service providers was that because we were not with our clients, the caregivers that were with our service users in their home became half of what we would be. On this side of the screen, we were really just providing the music. We were giving as much positive verbal reinforcement. We were giving as much direction and cueing and structure as much as we could through the screen. So it became really important to the success of the service user to have a very engaged care provider with them. And that care provider was sometimes a mom or a dad, a personal care attendant. And you'll hear more about their thoughts and their perspectives in a little bit from the students. But we did a lot of observing of how effective are our cues being on not only the service user, but also on the caregiver's ability to accurately model and engage their loved one, basically doing our exercises, our techniques. And you'll learn more about what those music therapy interventions were in a second. We then did a lot of action and then practice. And that's the third component to coaching, where maybe we had to do as much modeling as we could to show the caregiver and to show the service user how to do what we're doing and what we need them to do. And then we would go back and forth between observing what they're doing and doing action ourselves or putting it into practice. And then we would go to the fourth component, and that is reflection, where we would have an opportunity just to kind of stop the music or maybe have a little background guitar playing going on just to keep music there. And we would have some very open, honest, transparent reflection with both the service user as well as with their caregiver to see, are we seeing success? Because we're far away, we're through the computer screen. Maybe we couldn't see the whole body or the whole affective response of the service user. And so we wanted to have a reflection opportunity or reflection time with both care provider and service user to make sure that what we were seeing was accurately happening in real, in person. And then near the end of each session, we would give feedback. And oftentimes this feedback, and this is the final component of the coaching orientation. With feedback, this would be where we might assign homework, or we might say, hey, between sessions, right? Because we all know that great things happen in our sessions, but it's really all about what happens between sessions, that generalization that we want to encourage in our service users. We were trying to give both service users and caregivers tips and tricks and feedback on how to continue these exercises between sessions. So we found this coaching model, this model that comes out of the family-centered practice approach within early childhood education, or early childhood special education, very helpful and very effective in our telehealth approach. And I've always been really excited to roll it out in person, and hopefully soon in the coming months, we'll be able to do that and measure that more effectively with our service users. Okay. All right, so I think that takes us to Emily.
All right. Hello, everybody. So my case study is with a client who's a teenager with cerebral palsy. And so initially what grasped me about this whole situation is just how amazing and involved her father is. He came into the first session like, oh, we have a guitar so that she can practice the fingers spread, reach out and strum like we do every session as kind of a warm up. And so he had that ready to go the first time. And I was like, wow, he's finding ways to bring music therapy that would be in the clinic into his home more than just having us on a screen. He also, so we had a bit of a setup for this session. We'd have 3 tambourines on a tabano with a drum on the floor that she would knock off 10 times per arm. And then we do that again. So it's a lot of picking up tambourines, and usually that's my job, is chasing them around the room as they roll away and bringing them back to set up. And without a blink of an eye, he was chasing them and setting up, helping us move the camera so that we could see, all right, how is her control of her gross motor arm movements? And also just the modeling. So for example, again, with the spread fingers for guitar, I mean, we can get close to the screen, but it wasn't as effective as when Dad right next to her showed her, this is what spread fingers looks like. Help her relax her hand to say, this is what this feels like. Because he is at every session with us in the clinic. So he knows, he watches, he observes. And so seeing him really just step up in that way was just amazing. And for finding silver linings, I'm gonna go into a specific story. There was one session where about 2 or 3 minutes in, Professor Schwartzberg froze, and I was like, okay. But then Dad said, oh, I can still see and hear him just fine. I'm like, oh no, like this is it. I'm lost, I'm confused, I can't see my supervisor, but everything else is fine. And so we kind of just utilize the chat function, and where being behind a screen strips all those nonverbal cues, or a lot of them. Now I had 0 and I had no verbal cues. So it gave me a lot of independence while also trying to follow the tertiary cues of, okay, I'm seeing how the client and the dad are reacting to Todd. So then what do I think he's doing and how do I adjust? And just a lot of back and forth via chat, and okay, so we're moving on to this next thing now. And I'm like, awesome. And afterwards, Professor Schwartzberg, like, you know, you were doing a lot of the same positive verbal reinforcements at the same time as me, which I thought was pretty fun. That I learned from him so directly that even without the verbal and nonverbal cues from him, I was just following along in his footsteps. And so from the parent perspective, the dad of the service user contributed that the kindness and the patience from the music therapist and student music therapist was what made it so successful, which is really sweet. And the ability to continue the treatment plan, even though it was through telehealth and virtual. So again, he came in that first day, like, okay, so I got some tambourines and I have this guitar and the maracas as well. We used maracas at one point. And he appreciated that we stood steady on our end of the bargain as well, that we're going to keep working on our goals because those goals are still important even if we're not in person. Yeah, that's my case study.
Emily, that was absolutely fabulous. From my perspective, as I got to watch this session, one of the things that struck me as well was how the dad was able to, and you said this, I just want to reinforce it. The dad was able to replicate all of the music therapy interventions that we had practiced in person. So one of the things that it was an advantage to us and an advantage to the service users and caregivers was we had prior experience working with them in person in the on-campus music therapy clinic. Even just weeks before we had to start telehealth. And in this case, this dad came to every single session and was in the session with us. And so he saw that, oh, they're stacking 3 tambourines on this tabano and we're working on neuromuscular coordination, encouraging my daughter to push these off very carefully and slowly. And so when we approached Dad and asked him, would you be amenable to switching over to telehealth? He said, absolutely. And I had a brief little conversation with him and he said, Todd, don't worry about it. I got everything covered. I said, awesome, cool. And then Emily and I showed up for the first session, like Emily just said, and I was blown away, so inspired by the dedication and commitment and resourcefulness of this father. He went out and got maracas. He went out and got tambourines. He found an end table and put the tambourines on the end table. He became us. And I thought that was so cool. And it fit the coaching model so very well because he had seen us do it. He felt empowered and comfortable not to be a music therapist, but to be a dad doing music-based exercises with his daughter as the music therapist provided, and in this case, student music therapist provided brilliant coaching, cueing, and reinforcement. So I was just blown away by that, and that was awesome. All right. So the next amazing student that we get to hear from is going to be Elsie.
Thank you, Professor Schwartzberg, and everyone else for letting me be here. My case study was a young man aged 24 with 22q11 deletion syndrome and autism. And our goals before and during COVID, telehealth, everything was improving his articulation and rate of speech, so this involved a lot of songwriting, a lot of rhythmic chanting and cueing. He's an amazing drummer, so we got to do a lot of drumming. So with the drumming, we used to do this drumming and movement activity to help his self-regulation before we would begin our sessions in person. And so now we weren't able to do that. So that was one thing we missed out on, but we got to continue with our songwriting, which I found it was super helpful for him. He was really great at it. So we were able to involve his PCA would always come to the sessions before quarantine, but after telehealth and he was at home, Mom got to join too. And I had never met her before. She's super sweet. She was super amenable to joining us. And so it was really great to see her. And because we were able to involve another family member, we were able to further generalize to his environment. And it was very lucky. He had a ton of drums. He had all kinds of stuff at his house that we got to use. And so we were able to transfer our drumming activity kind of with the rhythmic chanting in addition to the songwriting activity, which was to help him slow his rate of speech, speak clearer. And when technology was working well with us, we were able to use screen sharing, and this made it super easy to read. We were able to quickly change things, move things around, write out all the different questions we would have him ask. He would get to talk to Mom, his PCA, and we would talk about what he would do while we were in quarantine, because he used to be so involved with his community outside of the School of Music and outside of his household. And now he wasn't able to do that. So we were like, so what are we gonna do on this summer day when we're trapped inside? Are we gonna go on a bike ride to the park? It was great. That was probably my favorite advantage of telehealth, was that easy generalization to the environment. And as you can see from his mom and PCA, they also really valued that consistency and that sense of normalcy after we had to change everything about what we were doing. I thought that despite how much I really wanted to continue being in person, that quarantine and telehealth really provided an opportunity to go beyond our comfort zone and be able to generalize to the environment more than what is possible in our clinic room. And I'm sure Professor Schwartzberg can attest to that even more. And it was great. It was a great opportunity. I felt very lucky that when it had to happen, it happened this way.
Trying to find the unmute button. I'm sorry, y'all. Elsie, really well done. Absolutely. From my perspective, I shared this about Emily's client, and I'm going to share about yours and also Emily Adamson's client too. When we entered into synchronous telehealth with our service users, one of the things that did not dawn on me was how they were giving us permission to come into their home that had their smells, their distractions, their comfortabilities, their home field advantage. And Emily's going to get at this a little bit more, but I wanted to bring it up with this client too. Prior to me having the privilege of being at the U of M, I worked for a community music school, and part of that I did in-home music therapy. And so I went into the clients' homes, but it had been about a decade or so since I had that privilege, and I had forgotten completely about how much extra work it is on us, the service provider, to redirect. And in this one client's case particularly, and we're going to hear from Emily Adamson too about her client, they sometimes got very distracted by other things in their environment. So one of the strengths that we did, and Elsie did this fabulously, and this client did this fabulously, we use those distractors. We use those other things in the environment to work on our goals. And in his case, some of those goals, as you were saying, were clear articulation and rate of speech. That then also transferred to social initiation, reciprocity, maintenance, and termination. So while it first struck us as, oh my gosh, what are we going to do about this home field advantage? We use that home field advantage to our advantage. Is kind of the takeaway. So great work. All right, so the next amazing student that we get to hear from is going to be Emily Adamson.
All right, awesome. So the case study I get to present is with an individual who's 24, diagnosis of ASD, cerebral palsy, and hydrocephalus. And this particular service user presented with a stutter, and that was what we spent the majority of our time working on. Our primary goal was improving rate of speech and vocal inflection, and we did a lot of interventions. We were singing through sentences and encouraging that calm, steady voice. But what I quickly realized over telehealth was that internet was going to be a problem, because sometimes you can't tell if the client was stuttering or if the internet was making it seem that way. So we had to pretty quickly adapt to this. I'm sure we all know how hard internet can be. And when the world moved virtually, I was expecting a lot of glitching, but I didn't think about how it would affect in this therapy setting. And yeah, so I think what I noticed the most was that in a Zoom call or a telehealth session, sometimes we don't completely cut out, but will like break in and out. And it became really challenging for me to differentiate between what was the internet and what was something that we could address with our goal. And ultimately, we just had to find this balance of being really gracious to our client and to ourselves, and figuring out how to navigate this and being okay with repeating ourselves, and also being okay with acknowledging the internet is not that great today. So maybe we're not going to get as far along as we would have hoped. I also had unlike my colleagues, I had the unique challenge and opportunity to only work with our client virtually. So there were a bunch of scheduling conflicts that made it so that my first day with this service user was also the first week of telehealth. So while the service user was getting used to Doxy and seeing Professor Schwartzberg over a computer screen instead of in person, they also had to figure out who I was and what I was doing there. And there were two pretty big obstacles in that. The first was, how do we create this working alliance over Zoom? I am thankful that I am a practicum student, because there was a working alliance already there with my supervisor and the client, but I had to figure out, how do I make the client feel comfortable with me and feel comfortable with me over a computer screen? You don't get to see, my whole persona and smiling face as well. And I think what we did the best in that situation was just letting our client go maybe a little bit off task. That was where we used that home advantage of letting the client kind of show me a little bit more of their life at home, and then they felt more comfortable with me being there and leading. And the second obstacle, which kind of relates to the first one, is by meeting this service user over telehealth, I didn't have a baseline to work off of for our intervention. So while I was learning how to navigate Zoom, I was also learning our service user's language and learning more about their stutter and where they were at, and navigating how to grow without really having a clear understanding of where we started. And Professor Schwartzberg mentioned that we didn't reevaluate over telehealth, but I think it would have been really interesting to see what would have happened if we did, because I was not evaluating, but I did get some of that. How do I figure out where we're at with only getting this half interaction? And lastly, I just want to talk about these barriers. So we mentioned this home environment. So this particular service user, every week was something new. Sometimes we were on a phone, sometimes we were on a tablet, sometimes the service user was in bed, other times out with mom in the living room. So each week we didn't know where we were coming into, as opposed to when they come in the clinic, we know how we're going to set up. We know that we're going to hide the distractions, and we're going to really be focused. And instead, every week I logged on and I was like, okay, where are we? What are we doing now? And so we have to roll with that. We have to figure out what to do. And I have heard that things have changed this semester, and I do know that this service user now has a desk and a computer, and I think mom really understood that maybe we need a little bit more routine, but even without that, we made it work. And one of the really interesting barriers that I found was actually between myself and Professor Schwartzberg, and this communication that's happening between a practicum student and the supervisor that's really continual throughout the session. And before and after sessions, we'll evaluate and talk about what to do, but during the session, it's a lot of nonverbal communication. So in person, I think about how, if a client throws something at me that I'm not expecting, I might shoot a look to my side of, help, how did we get here? Where do I go? I don't know what I'm doing. And a lot of times that's met with, you got this, keep going. But other times the supervisor will step in. But over Zoom, if I were to make a face right now that showed complete fear, you'd all see it, not just the person I'm trying to show. So we had to navigate, how do we communicate, especially as this was my first few interactions with the service user, how do I communicate that I need help, or I'm not sure what they just said, without making the client feel like they're kind of stuck in between. And so that's where the chat feature came in handy. And I also think that was another case where we really just had to take things slow and be okay with things maybe not being the same as in person. Obviously, they're not the same. And just being okay with taking our time, and things might not go always as planned, but it will all end up all right in the end. So our service user's perspective, I love this first comment. The mom noted on the similarity between the clinic and home, and I think that's great. I don't know what it was like in the clinic, as I mentioned, but it really is a testament to what Professor Schwartzberg was doing, and really keeping things consistent. I know I can relate to that with school. I really was thankful when things stayed the same, especially when everything else is changing. And she also noted how we were able to make COVID fun. And I think it's important to clarify that we don't mean COVID is fun. Mom knows COVID's not fun. In this particular case, actually mom and service user were both immunocompromised. And so they were home majority of their days for the entirety of COVID. They're still stuck at home a lot. And so I think music therapy really offered this break from the daily. It was something that they could look forward to when everything else was canceled. And I am really thankful that we got to be a part of that. And I hope that music therapists around the US and around the world are continuing to do that, because for these clients and these service users, it can make all the difference when not everything is super fun right now.
Very well said. I have known this particular service user for quite some time. Some of you may know me in that one of the things I get to do during the summer months is work at a summer camp for individuals with autism. And so I have actually known this service user for, I don't know how many amazing years, but I have known him since he was about 10. So I guess 14, but 10, give or take. And because of that, I've grown with him and he's grown with me. One of the things that absolutely just warmed my heart, and I could say this for all three of our students who gave their time through telehealth and are speaking so eloquently and professionally this afternoon about their amazing work. One of the things that absolutely warmed my heart was how Emily and everyone else, but Emily specifically, because you didn't have that relationship with this client, you built that rapport so quickly. Telehealth is a barrier. We know that. We are trying to give ourselves, we're trying to build relationship, we're trying to increase rapport and working alliance, and we're trying to help our service users make progress to become as independent as possible. And when you first start that relationship out through a computer screen, that's not great, but it is what it is. And you recognize that at the beginning. Your patience, your diligence, your positivity, your optimism bled into the same response in the service user. And I thought that was just absolutely fabulous. And I think that helps set your service user up for success. I want to go back and I want to reflect on what you said at the beginning regarding the internet glitching. I agree with you wholeheartedly. We have spoken, I think this week, regarding a different service user. And we are working on articulation, and particularly articulation differentiating between a T, which is at the front of the tongue, and a K, which is at the back of the tongue. Both are hidden articulators. When I'm in person, we are in person with our service users, we can see that a little bit better, and they can see that on us a little bit better, and we can hear it. We can differentiate between that sound a little bit better. One of the downsides that happened with this client, and similarly with this other client this week, is, are we accurately hearing the subtle articulations? And so I think one of the things that really challenged us, and this is my reflection on your work with this client, Emily, is we had to be extra Sherlock Holmes. We had to really listen in to make sure that what we heard is what we heard. Now, one of the nice things about this is using that family-centered practice model and using that coaching aspect of it, in that we had the privilege of having the service user's caregiver there with them. And that helped give a little bit of validation. But sometimes with this client, service user left, or the caregiver left the room, and we didn't get that validation or that reliability. So it's just one of the things that that's my reflection on you, is how careful we had to be. We used each other for reliability, and when the caregiver was there, we used that as well. So nice work. All right, folks, this is going to be our wrap-up slide, and then we look really forward to taking any questions you may have, or even thoughts and perspectives that you may have on your own telehealth work, because we are all learning through this process. One of the things that all of us feel from our perspective with the service users that we are currently working with is that for us, telehealth was doable. There were some things that we had to think about in order to get to that point. We recognize that not every service user in every environment and every treatment plan goal and objective, goals and objectives will be doable. But for our particular clients, we felt that it was doable. And I hope that you see some of the evidence that supports that. I'm working with a client right now, with a service user right now, and one of the challenges that we're having, and we're kind of on the fence right now about if we want to do telehealth or maybe take a break or maybe think of other avenues. One of the things that we're having a little bit of struggle with is social and emotional regulation. And I'm trying to do my very best to assist them in that. But it's just me and the service user. And then sometimes there's a PCA there. But the ability to really get into doing some appropriate social story songs and doing some role modeling and eventually maybe some video modeling, some of that's being challenged. And so that may be one area, among maybe some others too, that may be challenged. Now, I am the kind of person that I will think outside the box, and the students can attest to this. I will think 20 steps ahead and I will figure it out as long as it does benefit the service user. So I'm not saying no, and I've got a few ideas and brainstorming things and stuff that we're working on, but I don't want to give the impression that we're saying that telehealth is 100% doable. There are some challenges. And so some things to help with those challenges: consult with the family. Think about privilege. And I know this is not the topic for today, but we are privileged. We are privileged to have Wi-Fi. We are privileged to have computers. We are privileged to have, in this case, a microphone that I think, still not entirely convinced, is helping with helping with sound processing. There's a lot that we are privileged to have, and some of our service users and their caregivers, they don't have that privilege, and that's not okay. But we need to recognize that. And I was telling the students as we were preparing for this that if we find out that a service user has been referred to us, and we find out that they don't have access to Wi-Fi, or they don't have access to a computer, or they don't have access to certain other types of technology to make this accessible to them, then we need to try to do something about that and not just say, I'm sorry, I can't service you. Let's call up some foundations. Let's call up some organizations. Let's find out if Target, Best Buy, Honeywell, Medtronic, I don't know who else. I'm just throwing out names that are here in the Twin Cities. Can maybe donate some computers, donate a router or other things that are needed. The access means a lot to me. And I don't ever want to have to turn a client away because they can't access our services. So I think it's incumbent upon us to at least ask. And if we get told no by these organizations and foundations, at least we know we asked. But I'm not going to stop at no. I might stop at the fifth no when they tell me to go away, but then I might not even stop. So anyway, whatever. That's a soapbox that we don't have time to get onto. But think about technology. What do the service user have? What is their computer? Do they have a webcam? Do they have a phone? Do they have an iPad? What is it that they have? And then think on yourself, how can I make use of what they have so that I can set this up to be successful? In the environment too. We are all in this new normal, which hopefully won't be normal for much longer. And then we'll have a new normal. But what can we do to change our environment so that there's no distractions? And if there are going to be distractions in our environment, like for instance, I have a junior in high school who is doing complete online school at home all the way through January at least. I know she's here, and she knows when to turn her Wi-Fi off, and she knows when it's okay to have her Wi-Fi on. But know those things. Sometimes I sit here when I'm teaching or when I'm having meetings and stuff, or sometimes I have this tilted more where the guitar is and the piano and my at-home instruments are. So think about the environment, and then think about that for your service users too. Y'all heard us speaking about that today. Take the time to get to know what they have in their environment and make use of that so that it doesn't become deleterious on the progress or potential for progress of your service user. And use all the resources that you can possibly come up with. We have one client I actually worked with today just before this call. He has no instruments at home, but we came up with the idea that, you know what, we're just going to use kitchen utensils because he loves playing the drum. He needs it for rhythmic speech cueing support and assistance. So his mom actually told me that for 30 minutes before the music therapy session today, he was already sitting in his recliner with his pizza pan on his lap and his wooden spoon, and he was already making music, waiting for music therapy to start today. So think about the resources that the family may have. Okay, something else, and this has dawned on me as I've had the privilege to teach more through telehealth and internet synchronous opportunities in our classes, and also deliver telehealth. I have to be bigger than usual. We convey so much with our affect, and we know the data and the studies that talk about that. We convey so much sometimes with our arms. We need, because we're through the screen and from miles away from our students, and as well as in this case from our service users, our affect needs to be bigger. Our posture needs to be modeling and bigger. We don't need to be obnoxious, right? We don't want that. There's that happy medium. Students know I love to use Goldilocks as a metaphor, where it's not too little, it's not too much, it's just right for each service user that we get to work with. So we need to find that happy medium, but we need to know that we need to convey ourselves through the screen, because our energy, our commitment, our dedication, our drive feeds our clients and feeds their caregivers as well to, on the other side of the screen, be dedicated and committed and participatory. And then engage the family and the service user as much as you can. This is why I love the family-centered practice approach. And the more I get to read about it and research it and write about it and listen to others who know way more about it than I, the more I'm just more in love with this approach. The family, and I've said this for many, many years, the family knows their son and daughter better than I ever will. The family knows their loved one better than I ever will. It could be a mom to a dad or a sister to a brother. It could be any family member. But we know music therapy, and we know how to skillfully and intentionally create music therapy experiences that are measurable and obtainable for our clients. And so you merge those together, and we can really work wonderfully through telehealth and for generalization. And then I started talking to the students the other day about this word called hope. And Emily Adamson brought it up just a little bit when she mentioned how the mom commented that, quote, "You made COVID fun." I feel like one of the things that we don't talk about enough is the hope, the optimism that we bring, or that we create for not only our service users, but for their caregivers as well. To get to see your child, in our case, it was children, to get to see your child succeeding when sometimes I just drop them off at therapy or a PCA takes them, to get to actually see my child work hard and succeed. And when the music is fading, be able to generalize those skills, that gives hope. And I don't exactly know how to measure that. I know there's some hope scales out there, but I'm not exactly sure how to measure it. It's such a subjective, beautiful term. But I think it's something that we should feel good about, that we do bring hope, especially in periods of history, such as what we're living in. We do get to bring hope to those that we get to work with.
Thank you so much, Professor Schwartzberg, and also to you, Emily Yager, Elsie, Korioth, and Emily Adamson. Really appreciate all this amazingly innovative work that you all have accomplished during this difficult time. And and really being innovative and this kind of uh, working so hard to find that way of connecting and making it happen for them despite all these barriers. So I think it's wonderful, the work that you all did, and then thanks again for sharing it with us today. We have gotten some questions that have come in, but we want to also kind of get a little bit more information from those who are viewing today. So we've got some poll questions that have just popped up here. So if you could just, this is for our participants that are joining us today, if you could just take a look at these poll questions and give an answer. The first one is, has COVID-19 impacted your ability to conduct music therapy sessions in person? And can go ahead and answer that one. The second one is, have you delivered music therapy services via telehealth in response to COVID-19? And then the final question is, do you intend to continue using telehealth to some extent, even when you can fully return to providing in-person services? So it looks like, let's see, 100% have been affected. Their service delivery has been impacted by this. 100% have delivered telehealth music therapy during this time. And then an overwhelming majority, 82%, plan on continuing to use telehealth to some extent, even after this is over. So great. So we got the right people tuning in to this webinar today. Thank you all for sharing that. It's really helpful to have that. Okay. All right. So, all right. So let's move into some of these questions. Boy, we've got a bunch of questions from folks. So the first one I'd like to ask would be to the students. And let's see if I can just pull this up here. Yes, Emily and Elsie, what did you think was harder or easier to learn how to do via teleservices?
I'll hop in. So the immediate feedback of watching the service user and then adapting immediately, because, the barriers, I don't know if I'm reading this right. And so in the moment, adapting as we go, reading the situation through nonverbals was really challenging, but we made it work. Yeah.
Yeah, I can bounce off of that. A lot of what we were doing was taking a sentence, writing a song on the spot, and then going right into that. And I think that's totally doable over Zoom. Like we've talked about, this is possible, but it was hard to kind of take that and jump in without having that energy to bounce off. I was in my own space and suddenly had to think of this song. And I think it's easier to get off track, not just for the service user, but for us as well. And so it's doable, but it was hard to bounce off that energy.
Well, thanks for those thoughts, both Emily's. Appreciate that. This question is for you, Todd. If you happen to use a standardized assessment tool, say one in autism or other ones with other populations, do you know if there's anyone doing revalidation studies on those measures using telehealth?
Is that a question from Barb? That sounds like a Barb question. That's a great question. Nice thumbs up. Barb, great question. We do not use any standardized assessments with the clients that we get to work. I love this question. We don't get to use any standardized assessments. I don't have any training in administering the ADOS or any other assessments. I get those assessments as part of the information that I request from the parents that help me develop our treatment plan. What was the other part? Am I aware of any? Risa, where is your? I got to see their question. I need the visual support. Where is that? There it is. Do you know of anyone who is doing revalidation studies on the measure? No, I don't. Wow, what a great question. I tell you what I'll do. I'm going to copy and paste that and put that somewhere else. And then I'm gonna do a little ResearchGate search and Google Scholar search, and the Jennifer Whipple and I are actually gonna be chatting a little bit about the other stuff next week, and I'll let you know. I have no idea. That's a great question. Sorry, my friend. I wish I had better answers for you.
There's actually a lot of really great information in addition to the questions here in the chat. I'd encourage everyone to just kind of take a read through those. This other question that came in from Dr. Gooding, Todd, considering all of the things that are challenging about telehealth and adapting it, what do you find easier or harder to teach in this virtual environment?
Oh my goodness. Oh, Dr. Gooding, what a great question. Hi, Lori. Sheesh. Oh, what do I see? I feel like physical goals, motor goals, gait training, particular. I have one client who I was working on gait training with, because we have this beautifully long hallway outside of our clinic, and I can't do that. I can't stand up and be a model and do that kind of stuff. The service user that Elsie was talking about, we were doing, no, I'm sorry, Emily Yager was talking about, sorry, spastic in her upper extremities. And so we were able to model that better just from a sitting position, and the opening of the fingers, like she was talking about, to reach out and strum on the guitar. We were able to show that on the video screen. So that was a little bit easier to do. I think communication, I think rate of speech, I think inflection, some of those things that are also more auditory for us to hear. I think we're fine in a telehealth kind of opportunity. Social skills, like I was saying too, I'm having a little bit of trouble with social skills because I feel like I'm practicing social skills, how social skills might be if we're in telehealth versus if we were doing social skills in person social skills. There's just no generalization there unless there's another caregiver or a PCA or someone else at home with the service user. But otherwise, I'm open to working on social skills. Absolutely. I love doing that, but that's one of the ones I'm kind of on the fence with. So does that, were you talking more clinically based or more like in the classroom teaching wise?
I think that it was
Clinical?
a general question about,
Okay.
From an educator perspective. And I think, yeah.
Okay.
I think that there, there's
Either
lots
way
of,
was good, Todd. Either way was good.
Oh, okay. Thank you.
yeah. Yeah. I really appreciate you all doing all this work, and I want to be mindful of everyone's time. We've reached our time today. So I want to thank our presenters, Professor Todd Schwartzberg, students Emily Yager, Elsie Korioth, and Emily Adamson for sharing your telehealth music therapy work in this session. I just really appreciate all of the work that you all put into this at an incredibly difficult time for all of us, and for making that happen for your service users. I think the points that you brought up today are really giving us opportunities to think about what are our next steps for in terms of research questions, in terms of what kind of curriculum should we be considering for the future of music therapy, knowing that telehealth is going to be part of our approach in the future. So really excellent discussion today, excellent presentation. And thank you to everyone who's joined us today, and also those that may be viewing this as a form of a recording at a later date. Please mark your calendars to join us next Thursday, October 1st at 8 p.m. Eastern Standard Time for the next webinar in our Grand Round series, Into the Unknown, Navigating Change in Your Music Therapy Business, presented by Amy Foley and Jennifer Pinson. Stay safe and be well, everyone. Bye-bye.